Now you've gone through all of the basics, you'll understand why we have studied so much. So let us start with the drugs acting on the parasympathetic nervous system. Now, we have two kinds of drugs. One class of drugs will increase the functions of parasympathetic nervous system. That means it is almost working like parasympathetic nervous system. It is mimicking the parasympathetic nervous system. So we call it parasympathomimetics. Now, the other class of drugs will decrease the function, so we call them parasympatholytics. Lytics means lysis, so it is decreasing the function, so it is parasympatholytics. Now, if you remember, what is the neurotransmitter in the parasympathetic nervous system? It is acetylcholine. See here, acetylcholine is present both in ganglion and near the organ. So, we can call it cholinergic nervous system. We can also call it cholinergic nervous system. So that is why these are also known as cholinergic drugs, and the parasympatholytics are also known as anti-cholinergic drugs. So we're going to study about two classes of drugs. They are cholinergic and anti-cholinergic drugs. I want you to understand this much. So in parasympathetic nervous system, we have cholinergics and anti-cholinergics. Now, what are the neurotransmitters? It is acetylcholine. What is the receptor? Muscarinic and nicotinic. Now, you understood the types of nicotinic receptors. What I want you to tell you is, neurotransmitter acetylcholine, how is it formed? So, let us suppose this is one nerve terminal. Now, which nerve terminal am I taking right now? See here. Let us suppose I am taking this part. So what are we seeing here? We are zooming in this part. So this is the nerve terminal that I have taken it. I have turned it this way. So upwards I am seeing the nerve terminal, and here is the effector organ. So let us suppose this is the orientation of the diagram. This is the organ and this is the nerve terminal. Now in the nerve terminal, let us see how is this acetylcholine formed. All the cells in the body will have acetyl coenzyme. Will you accept? Yes, you have to. Why? Because glucose is converted to pyruvate, pyruvate is converted to acetyl coenzyme A in the link reaction. You must have studied this in biochemistry. So we already have acetyl coenzyme A inside, but what we don't have inside our cells is choline. So we take choline from outside, both of them will combine together to form acetylcholine. Now, whenever the signal comes, this acetylcholine is released into the synapse. That is why it is known as neurotransmitter. Now, if it has to be released whenever you want, it has to be stored in something. So that storage area is known as vesicle. Inside the vesicle, acetylcholine is stored. Now, whenever signal comes in this nerve terminal, obviously signal comes in the form of action potential. This action potential will activate the calcium channels. So the calcium will move inside. This calcium will act on the vesicle. This will cause contraction of vesicle. So when there is contraction of vesicle, this vesicle will fuse to this synaptic membrane. You can see here, this is the vesicle that is fusing with the synaptic membrane. Otherwise, the nerve terminal is supposed to look this way, no? Now, why is it looking like this? Because vesicle is fusing with this, and acetylcholine is released. Okay, good. Now, this acetylcholine will act on the receptors like muscarinic and nicotinic depending on the site. If this is muscle, this is supposed to be NM. Yes, if this is eye, it is supposed to be muscarinic receptor. So, the acetylcholine will act on the muscarinic receptor to produce its function. Now, what is the function of muscarinic receptor in the eye? I have already told you, parasympathetic nervous system in the eye causes meiosis. Now, acetylcholine, if it binds to the NM receptor, it will cause skeletal muscle contraction. So, did you understand this much? Neurotransmitter has to act on the receptor to produce the functions. So this is how in the body the functions are generated by our nervous systems. Yes. Now, after its function, the acetylcholine will be metabolized. In fact, acetylcholine will act only for a very short period of time, even in milliseconds you can call it. When this acetylcholine acts on the receptor, it is detached from the receptor, and this will be metabolized by acetylcholine esterase. Why are we calling it acetylcholine esterase? Because it breaks the ester bond present between acetylcholine. Now, when this is broken, it will form acetate plus choline. So this is the same choline that is going up into our body. That is why we call it reuptake of choline. What do we call it? We call it reuptake of choline. So we are recycling the choline. This is what is happening. Acetyl coenzyme A plus choline forms acetylcholine stored in the vesicle. Then it is released. It acts on the receptors. Then it is metabolized by acetylcholine esterase. And acetate plus choline is formed. Choline is reuptaken. This is the rate limiting step. Rate limiting step is the main important step. If you activate this step, the reactions will go very fast. If you block this, the reactions will be stopped. That is what is rate limiting step. You must have studied this in biochemistry. Now, why did I tell you so much of this? Let us try to see. Now, let us start with the drugs called cholinergic drugs. They are also known as parasympathomimetics. In these drugs, there are two classes. What are those two classes? First class is direct acting drug. The next class is indirect acting drug. Try to understand this mechanism. If you know this, you know almost entirety of pharma in this just one concept. Please try to understand. See, how are we getting the effect? Let us suppose in the eye, we'll talk about the eye. When muscarinic receptor is activated by acetylcholine, it causes meiosis. Now, if you want to cause meiosis by yourself, by giving a drug. So, let us suppose you are giving a drug from the outside and it acts directly on the receptor. It acts directly on the receptor and it will increase the function. If it is acting directly on the receptor, it is known as direct acting drug. That's all. It acts directly on receptor, so we call it direct acting drugs. So if we give a drug that looks like acetylcholine, will it act on the receptor? Yes, it will. That is what is known as direct acting drug. If it is increasing the function, that is what is known as agonist. If it is decreasing the function, that is what is known as antagonist. That is what we have studied. So we have finished the direct acting drugs. These are agonist and antagonist. Now, let us suppose if we don't have a drug that will look similar to acetylcholine, but you still want to increase the functions. How can you do this? Remember, understand. Yes, how can I do it? Let us suppose if I increase acetylcholine levels. I told you acetylcholine is working only for a milliseconds. Yes. Now, if I increase the levels of acetylcholine, can this act on the receptors for longer period of time? Can this increase the functions? Yes, it can. So, these are indirect acting drugs. What are we doing? We are not acting directly on receptor. We are acting indirectly on receptor by increasing the neurotransmitter. So, we are acting on neurotransmitter. In cholinergic drugs, we are increasing the neurotransmitter. How can we do this? That is the mechanism of action. You try to understand. How is acetylcholine metabolized? It is metabolized by acetylcholine esterase. So if we give a drug and block this acetylcholine esterase, will acetylcholine be metabolized? No. The levels of acetylcholine will increase. It will act on the receptors. Then you get the effect. That is what are the classes of drugs. So these are the classes of drugs. What are they? Direct acting, indirect acting. Direct acting means acting directly on receptor. Indirect acting means they act on the neurotransmitter. Bas ho gaya. So these are the concepts I want you to be comfortable with in pharma. If you understood this much, rest all is going to be a cakewalk for you. Now, why am I telling you this? See, from now onwards, every single line that I tell you is very important for exam. It is either a PYQ or PYT from NEET or INI-CET or from AIMS exams or from FMGE exams. So these are all the PYTs and PYQs. So I am not going to repeat it again by saying this has been asked in FMG, this has been asked in NEET-PG. Every single thing from now has been asked in exams. So I am going to cover the most important topics from now, and to understand those topics, you have covered and finished all the basics that are required. So let us see. We will start with cholinergic drugs. As I have told, cholinergic drugs means they act similar to parasympathetic nervous system, so they are also known as parasympathomimetics. There are two classes of drugs: direct acting, indirect acting. Direct acting means they act directly on receptors. Now, in direct acting drugs, we have two groups. First is alkaloids. Alkaloids means they come from the plants. Second is esters. Now, what are there in alkaloids? I want you to remember two drugs for the exam. First is pilocarpine, the second one is cevimeline. Please repeat it with me as many times as you can. Pilocarpine, cevimeline, pilocarpine, cevimeline. Very important. Pilocarpine, cevimeline. Now, let us try to see. Pilocarpine, I told you, it works similar to acetylcholine. That means it acts on the receptor and causes the function. So what are the functions of these drugs? Obviously, what is the mechanism of action? In the eye, it can cause meiosis, yes or no? Yes, it can. If it is causing meiosis, this meiosis is actually helpful in some kind of glaucoma. If you remember, it is used in which kind of glaucoma? It is used in closed angle glaucoma. It is used in closed angle glaucoma. Why? Whenever there is mydriasis, please study this in ophthalmology. Whenever there is mydriasis, what is happening? Corneo-iridial angle is closed and it will cause, or it will precipitate closed angle glaucoma. So in this person, if you cause meiosis, it will be helpful in the treatment. So that is why it is drug of choice in closed angle glaucoma. So this is the use. So if you know the mechanism of action, you will get the use. You already studied this in functions. Did you understand this much? Now, what are the side effects? I told you, this will cause accommodation. Now, whenever there is accommodation, let us suppose this is the eye. Let us suppose this is the eye. Whenever there is accommodation, that means contraction of ciliary muscles. Contraction of ciliary muscles. There will be pain, yes, around the eyebrow area, and it will cause headache or broache. So it is having headache. Next, it is also causing accommodation. Now, because of accommodation, whenever these muscles are pulled, it might pull this innermost layer. Now, what is the innermost layer? It is retina. So it might cause retinal detachment. Did you understand this much? Yes. So this is about the eye. Now, these will act similar to the parasympathetic nervous system. What is happening to the secretions? It increases the secretions in the eye. So it will cause lacrimation. It will also increase the secretion in the salivary gland. So it will cause salivation. So it is also increasing lacrimation and salivation. So these can be used in dry eyes and dry mouth. Don't you think? It can be used in dry eyes and dry mouth. Where do you see dry eyes and dry mouth? There is a syndrome in medicine that you must have studied where you see antibodies acting against these glands and destroying the glands and causing this keratoconjunctivitis sicca. That is Sjogren's syndrome. So in Sjogren's syndrome, pilocarpine can be used. Now we have made a new drug that is better than pilocarpine in Sjogren's syndrome. That is what is cebimelin. It is cebimelin. Did you understand this much? So pilocarpine, cebimelin. Pilocarpine is used in closed angle glaucoma. This is what I want you to remember. Now, if you are getting confused, easiest way to remember this, please see here, pilocarpine CA. So it is used in closed angle glaucoma. This is how I want you to remember it. Cebimelin is used in the Sjogren's syndrome. That's all. These are alkaloids. Now, coming to the second class of drugs, these are esters. We have finished with the alkaloids. Now we are coming to the esters. I told you ester bond is present between acetylcholine. So they are going to be similar. We have drugs called acetylcholine, methacholine, betanicol, yes, and carbachol. Now, in all of these, what is similar is the name choline. You can see the name chol in them. So whenever you see chol, it is a cholinergic drug. Easy way to remember. Now, two drugs are important for the exam. One is methacholine, the other one is betanicol. Methacholine is a short-acting drug. Betanicol is a long-acting drug. Long-acting drug. Now, short-acting drugs, are they used in the diagnosis or treatment? This is one more concept I want you to understand right now. In diagnosis, which one do you want to use? Yes. And in treatment, which one do you want to use? Easier one is with treatment. Let us suppose somebody is having hypertension. Do you want to give a drug that will act for 1 hour or do you want to give a drug that will act for 12 hours or 24 hours? Think. If you give a short-acting drug, it will act for 1 hour. You have to keep on giving the drug again and again and again. So you would prefer long-acting drug in the treatment. Yes. So long-acting drugs are used in the treatment. Okay. Short-acting drugs can be given in emergencies, or better one to say is short and fast-acting. Yes, emergencies. Now, most importantly, it is also used in the diagnosis. Which diagnosis? See, methacholine is used in the diagnosis of bronchial asthma. This is also known as bronchial asthma challenge test. Why? Let us suppose a person is having bronchial asthma, he already has bronchoconstriction. If we give methacholine is a parasympathomimetic. What does parasympathetic nervous system do in the bronchus? It will cause bronchoconstriction, it will increase the bronchoconstriction, and it will increase the severity of the symptoms. So now you know the patient has bronchial asthma. This is what is bronchial asthma challenge test. Did you understand this much? Now the problem is, if you give a long-acting drug in this patient, he will have bronchoconstriction for a longer period of time and he might die. So that is the reason why you give a short-acting drug for the diagnosis. Yes, so short-acting for diagnosis, long-acting for treatment. If you understood this much, let us see about betanicol. Now the thing with betanicol is it does not cross the blood-brain barrier. If it is not crossing the blood-brain barrier, it will act only in the peripheries. Yes, if it is acting in the peripheries, let us see, it will act on the organs that are present in the periphery. It will not act on the brain. Now, which organs are most important to us? Gastrointestinal tract and bladder. How to remember? B for B. Betanicol acts on the bladder. Now, in the bladder, what is betanicol doing? We'll see the mechanism of action. I told you, parasympathetic nervous system will contract the bladder. So, you can use this wherever there is no contraction of bladder. If there is no contraction of bladder, what do we call it? Atonic bladder. There is no tone in the bladder. Now next is post-op urinary retention. What do you mean by post-op urinary retention? See, during the surgeries we give anesthesia. Yes, once you give anesthesia, it will take some time for the organs to recover. Let us suppose if the urinary bladder is not contracting, the urine will stay inside. That is what is known as post-op urinary retention. Now you have to contract the urinary bladder. That is why we are giving betanicol. Same thing, if it is happening in the gastrointestinal tract, we call it post-op paralytic ileus. So you have given anesthesia, now these muscles have not recovered, so there is what? Constipation. The person is not able to defecate. So if you give this betanicol, it will cause contraction of gastrointestinal tract. So remember, B for B, betanicol can be used in bladder problems. That's all. We have finished the alkaloids and esters. Easy to remember. Alkaloids are pilocarpine, cevimeline. Pilocarpine, Ca, closed angle glaucoma. Cevimeline in the Sjögren's syndrome. Next, coming to methacholine, it is used in the diagnosis of bronchial asthma. Betanicol is used in the bladder problems. Where do you use it? In atonic bladder and post-op urinary retention or paralytic ileus. Thus, bus ho gaya. Yes. Now, we'll try to see the receptors. There is one question that has been asked in the NEET-PG and we'll try to cover it as soon as possible. Yes, after this chapter, we will do the questions. I've added the question there. Yes, when we are solving the questions, you will see that. Now, if any of you have attended my classes before, I've told you a simple story to remember all the receptors. Now, we don't have so much of time to tell you the entire story, but I'll give you the gist of it. Now, let us suppose you're going to classes for your FMGE or NEET-PG coaching classes, whatever it is. Yes, when you're sitting in the class, obviously you're trying to listen, yes, and understand the concepts as much as possible. Now, all of you guys, let us suppose all of you are sitting in a class and suddenly a beautiful girl walks in. Now, what would you do? That is my question. I know what you'll do, but let us suppose there are two people. One person is mature, the other person is immature. Now, what will this mature person think? Yes, see, passing this exam is more important. So he'll think with his brain. He will think, exam pass karna hai. We have to pass the exam, earn money and fill our stomach. So a mature person will first think with his brain and will try to fill his stomach. If a person is immature, what he'll do, he'll listen to his heart. He'll go behind the girl. At the end of the day, the girl will not say, okay, he'll not pass the exam, he'll not fill his stomach. Did you understand? So immature people will listen to the heart. Easy to understand? Now, why did I tell you this story in a short way is, see, muscarinic receptor, mature receptor, M for M. So I try to remember it this way. Muscarinic receptor is a mature receptor. So first it will listen to the brain and fill its stomach. So M1 first, it is present in the brain and it is also present in the stomach. It will fill its stomach. How does the receptor fill the stomach? By increasing the HCl. That's all. Now, M1 receptor in the brain can also increase the cognition. We have done with M1 receptor. Now, mature person will first listen to the brain and he'll fill his stomach. Then he'll go behind the girl. So he'll listen to the heart next. So M1 is done, M2 is done. Now what about M3? M3 is present in rest of the body. So everywhere else M3 receptors are present. That's all. So what are the functions we studied in the parasympathetic nervous system? Starting with the eye. Do you remember? M3 is present in the eye. In the eye, what will it cause? It will cause meiosis. Then coming to the salivary gland, it will cause what? Salivation. Next, coming to the bronchus, it will cause what? Bronchoconstriction. Next, coming to the GIT, it will cause contraction. But increased HCl is by M1. Contraction is by M3. That's all. Next, last is bladder. It will also cause contraction. That's all. So you can see here, M3 is present in almost everywhere, all of the organs, and it is causing contraction of which muscles? Smooth muscle, skeletal or cardiac? Try to see. Eye. If there should be meiosis, there should be contraction of radial muscles of iris. These are smooth muscles. Now, if there is bronchoconstriction, contraction of smooth muscles, bronchus are smooth muscles. Yes, bronchi have smooth muscles, GIT have smooth muscles, bladder have smooth muscle. All of these are causing smooth muscle contraction. So smooth muscle contraction means it is GS, GQ or GI. That is why I told you the receptors are important. That is why I told you before. GS, GQ or GI, smooth muscle contraction. Everything is stimulated except smooth muscle by GS. But smooth muscle is contracted by GQ. Why did I write M3 and M1 together? Because both of them are GQ. That's all. So muscarinic receptors are GPCRs. M1 and M3 are GQ receptors. How do you remember this? With the help of common sense. I've already told you how to remember the receptors. Now you can understand the functions of the receptors from the functions table, and GPCRs. You can also decode this with the help of the table that I've given about the GPCR. So you don't have to mug up anything. You can understand each and everything. Yes, that's all. Now coming to the heart. What is happening in the parasympathetic nervous system? I told you it blocks SA node, it blocks AV node, so it will decrease heart rate, it will decrease conduction. So we are inhibiting SA node, we are inhibiting AV node, so this is a inhibitory receptor, this is GI. So that's all about the muscarinic receptors. You can see here, muscarinic receptor, how does it look? We have 1, 2, 3, 4, 5, 6, 7. So it is a heptahelical transmembrane receptor. This has been asked in the exam before. What is a heptahelical transmembrane receptor? It looks like a snake, so it is also known as serpentine. This is GPCR. You can see in the previous chapter also, these are GPCRs. Yes, how is it looking? 1, 2, 3, 4, 5, 6, 7. So this is heptahelical. It is passing through the membrane, so it is transmembrane. It looks like a snake, so it is what? Serpentine. Serpentine heptahelical transmembrane receptor. So example of GPCR is muscarinic receptor. We've already studied one of the receptors, M1, M2, M3, and then we also know about nicotinic receptors, NN and NM. NM is present in the muscles, NN is present in neurons and ganglions. That's all. Now we have finished with the direct acting drugs. Now coming to the indirect acting drugs. You already know the mechanism of action. How are indirect acting drugs working? I've already told you. What is the mechanism of action here? It is acting indirectly on the receptor by acting on neurotransmitter. Since it is a cholinergic drug, it should increase the neurotransmitter or decrease it. Obviously, it should increase it. So how can you increase the acetylcholine? By blocking what? Acetylcholine esterase. If you block acetylcholine esterase, acetylcholine will increase and this will act on the receptors. You will get the functions. This is what is indirect acting drugs. Now again in this we have two classes of drugs. One is irreversible, the other one is reversible. What do you mean by irreversible? Irreversible means they will block the enzyme for a very long period of time. Let us suppose if we are blocking this enzyme for a very long period of time, acetylcholine will increase for a very long period of time. Now this acetylcholine will cause excessive functions, increased functions of parasympathetic nervous system. So it will increase the secretions Yes, it will increase the secretions everywhere and it will increase defecation, so it will cause diarrhea. It will increase the urination. Yes, it will increase the urination. Next, there will be meiosis, increased meiosis. It will cause pinpoint pupil. I think you must be correlating with this with some kind of poisoning that has been asked in exams so many times. Now, the most important thing is it is decreasing the heart rate a lot. So the person is having some kind of poisoning. The person might die. So we call it poisons. If we give irreversible blockers, they act as poisons. Did you understand? So you can see here, irreversible indirect acting drugs are insecticides and pesticides. These are organophosphates and carbamates. That's all. So that's all. These are the organophosphate and carbamate poisoning. What are the signs and symptoms of this? What are the signs and symptoms of this? You already know. Increased parasympathetic nervous system functions. What are they? Increased meiosis. So it will cause pinpoint pupil. We'll write all of this. I've given a table. Increased meiosis, pinpoint pupil, increased lacrimation. Now, increased bronchoconstriction, defecation, urination. So there is diarrhea, there is urination, then there is emesis, then there is bradycardia, all of these. That's all. So these are the irreversibles. These are irreversible acting drugs. Now, in this you must have studied in the poisonings. Why is organophosphate and carbamate poisoning happening? I've already told you the mechanism of action, because it is blocking acetylcholine esterase. So I've already told you organophosphates and carbamates will block this acetylcholine esterase. So it will increase the acetylcholine levels. Now, why are we getting the functions? Because it acts on the muscarinic and nicotinic receptors. Yes. So most of the functions that we know are because of muscarinic receptors. So what are those functions? You already know. I've already told you the dumbbells, no? Yes, there is diarrhea, there is urination, then there is meiosis, bradycardia, all of these things you will see in organophosphate poisoning. So the problem is because of activation of muscarinic receptors. So what should be the treatment? We should block the muscarinic receptor. So it is anti-muscarinic drug. So what is the drug of choice? It is an anti-muscarinic drug. Please try to remember this one drug in anti-muscarinic drugs. This is very, very important. Has been asked in the exams so many times. Atropine. So please remember this. Wherever you see a trop word, it is an anti-cholinergic drug or anti-muscarinic drug. So in cholinergic poisoning like OP and carbamate, we give an anti-cholinergic drug. Simple. If there is cholinergic poisoning, we give anti-cholinergic drug. That's all. So what is the drug of choice for OP and carbamate poisoning? It is atropine. Now, when you give atropine, all these symptoms will start decreasing. But what is the most common sign for this decreasing of symptoms? So when atropine decreases all of these symptoms, we call this as atropinization. How do you know the atropinization is done? What is the most common sign? Most common sign means easy to see. See, in this person, the patient will have pinpoint pupil because of lot of meiosis. So if you open as eyelids and see, and if there is increased pupil size, then that means the organophosphate effect has been reduced. So most common sign is supposed to be mydriasis. But what is the most specific sign? Specific signs means this is the confirmatory sign that there has been atropinization. What is it? It is normalization of respiratory secretions. Now, it is difficult for some people to understand if the respiratory secretions are normalized or not. So that is why even though if it is the most specific sign, we still look for the mydriasis because it is easier to see. That is why most common is mydriasis, most specific is still normalization of respiratory or bronchial secretions. Now, the most important thing is atropine will treat all the symptoms of organophosphate poisoning. True, except which symptoms? See, I told you acetylcholine will act both on muscarinic and nicotinic receptors. So whatever effects you are getting with muscarinic receptors, atropine will block it. Very nice. Now, what about nicotinic receptor? Nicotinic receptor is also present on the somatic nervous system. It is also present in the somatic nervous system. So if it is present in the somatic nervous system, now increased acetylcholine acting on NM receptor, what will happen? First, there will be increase in contractions. True, they are also known as fasciculations. But if the NM receptor is stimulated for a long period of time, it will stop working and it will cause muscle weakness. So because of its action on NM receptor, there is muscle weakness. Now atropine cannot block the NM receptor, so it cannot treat it. So atropine will treat symptoms of organophosphate poisoning except muscle weakness. So if you want to treat this muscle weakness, you have to give a drug that is known as PAM, that is also known as pralidoxime. So you give oximes. So that is the most specific drug for organophosphate poisoning, pralidoxime. So all of these are exam questions, all of these very, very important. Drug of choice for OP poisoning, carbonate poisoning, what is it? It is atropine. Most common sign for atropinization is mydriasis. Most specific sign, normalization of respiratory secretions. Next, it will treat all the symptoms except for muscle weakness. This has been asked in the previous recent FMGE exams. Yes. Now, what is the most specific drug for organophosphate poisoning is oximes, pralidoxime. But the important thing is oximes can be used only in OP poisoning. It is not used in carbamate poisoning. Now, how can you remember this? Please try to see here, organophosphates OP, pralidoxime OP. That's all. Done. So, most specific sign for organophosphate poisoning is pralidoxime. Now, if you understood this much, we have done with the irreversible. Now coming to reversible. Reversible means it will block acetylcholinesterase for some period of time and then it will be normalized. So it increases the acetylcholine for some period of time, okay, and it will give the function, so it is acting like normal drug, so we can use it in treatment. So irreversible drugs here are poisons. Reversible drugs can be used in treatment. Now again in reversible we have two classes of drugs. Try to remember this. One is tertiary amines, the other one is quaternary amines. What is important here? See, quaternary amines are water soluble. Problem with this? If they are water soluble, they cannot cross the blood-brain barrier. So they will act only in the periphery. How can you remember this? See, one of my students during the classes, he has given me a mnemonic. It is the easiest way to remember this. What is it? See, water. Where do you mix water? In the water. So quaternary amines are water soluble. This is what he has told me. Unfortunately, I have been using it. So quaternary amines are water soluble. Okay, so they will not cross blood-brain barrier. Tertiary amines are lipid soluble. They will cross blood-brain barrier. So they can be working in the diseases that are seen in the brain. Now, there is one disease where there is decreased cognition. There is an old person who keeps on forgetting things. Decreased cognition. What is it? It is dementia. Yes, dementia, Alzheimer's disease. In all of these patients, the cognition has decreased. Now, what did I tell you? M1 receptor is present in the brain, if you remember. See here, M1 receptor is present in the brain. It is increasing the cognition. So, if we increase the acetylcholine, it will act on M1 receptor. It will cause cognition. So, what are these drugs? These are tacrine, donepezil, rivastigmine, galantamine. Now, tacrine we are not using anymore because of hepatotoxicity. This question has been asked because of hepatotoxicity. Now, next question is, what is the drug of choice in Alzheimer's disease? It is donepezil. How to remember this? C, drug of choice, D for D, or easiest way to remember, Don is the most important person. So, donepezil is the most important drug in Alzheimer's disease. It is the drug of choice. Okay. Now, in the INI-CET exam, they have asked, a person is not taking the oral drugs frequently. He is non-compliant. So, what will you do in this patient? If a patient is forgetting to take drugs, Alzheimer's disease means he doesn't have cognition, he has memory problems, so he is not able to take the drugs. If you give oral drugs, he might not be able to take it. What will you do? You can keep a transdermal patch. So the answer is transdermal patch. When the question was asked, rivastigmine was the only transdermal patch that is available during that time. So the answer is rivastigmine. Did you understand? So these are the three options that have been asked in the exam. Tacrine, hepatotoxic, donepezil, drug of choice, rivastigmine can be used as transdermal patch. That's all. These are about the tertiary amines. Now, one thing is left out, it is physostigmine. Please try to remember this, physostigmine, very important. I'll tell you in the end, physostigmine, okay? Now, coming to quaternary amines. What did I tell you? Quaternary amines are water soluble, they do not cross blood-brain barrier, they will not act on the brain, they will act in the peripheries. Now, in the periphery, we have a disease. There is a disease that is causing muscle weakness, that is what is known as myasthenia gravis. Myasthenia gravis. What is myasthenia gravis doing? Let us suppose this is a skeletal muscle. On top of skeletal muscle, you have a receptor that is known as NM. When this NM is activated, you will have skeletal muscle contraction. In myasthenia gravis, there is formation of antibodies. These antibodies will sit on the NM receptor. If antibodies are sitting on the NM receptor, will acetylcholine act on it? Obviously, it cannot. Now, if it is not able to act on the receptors, what we can do? Let us suppose if we increase the acetylcholine. If we keep on increasing the acetylcholine, what will acetylcholine do? Acetylcholine will push this antibody outside and it will cause the skeletal muscle contraction. That's all. So, in myasthenia gravis, we have to give a drug that will increase the acetylcholine. So, which drugs increase the neurotransmitter? Indirect acting drugs. Okay. So, it should be reversible or irreversible. Irreversible means poisons. So, you have to give reversible drugs. Okay. Do you want to give tertiary amines or quaternary amines? If you give tertiary amines, it will act on the brain, it will have side effects in the brain. So you have to give quaternary amines. Did you understand this much? That's all. So that is why in myasthenia gravis, we use quaternary amines. What are these? Edrophonium, neostigmine, pyridostigmine. Now, how to remember this? Edrophonium is a short-acting drug. Neostigmine, intermediate. Pyridostigmine, long-acting. This is the schema I am following here. So, short-acting is edrophonium, intermediate is neostigmine, long-acting is pyridostigmine. Now, I have already told you, short-acting means it can be used in diagnosis. Long-acting means it can be used in treatment. So, in treatment of myasthenia gravis, pyridostigmine. Diagnosis of myasthenia gravis, edrophonium. Now, the test that is used for diagnosis of myasthenia gravis using the edrophonium is also known as tensilon test. These are the most commonly asked questions in the exam. Tensilon test and the treatment of myasthenia gravis, it is pyridostigmine, edrophonium. Pyridostigmine, edrophonium. You have to remember this when you are studying anesthesia. In anesthesia, you will also study about neostigmine. Really important in anesthesia. It is used for the reversal of NDMRs. NDMR reversal. You will study it there and you will understand it. NDMR means non-depolarizing muscle relaxant. Okay. So, how do I want you to remember it? Indirect acting drugs are irreversible, reversible. Reversible drugs are poisons. OP and carbamates, they are causing poisoning, so use atropine. Next is what? Reversible. Irreversible, tertiary, quaternary. Tertiary will cross the blood-brain barrier, so they can be used in the Alzheimer's disease. What are these drugs? Tacrine, donepezil, rivastigmine, galantamine. Now, what about the other class of drugs? These are quaternary, not soluble, not lipid soluble. So that is why they are not crossing the blood-brain barrier. It can be used in myasthenia gravis, edrophonium, neostigmine, pyridostigmine. Edrophonium is short-acting, so it can be used in the diagnosis. Pyridostigmine is used in the treatment of myasthenia gravis. That's all I want you to remember. Okay. So we have finished both the classes of drugs. So we have finished with the cholinergic drugs. These are direct acting and indirect acting. So one drug is left out, that is physostigmine. I do remember it. I will talk about it in the next chapter. Okay. And try to absorb all of this information inside. In direct acting, indirect acting. Direct acting में alkaloids and esters. Indirect acting में reversible and irreversible. Okay. And then we will start with the anticholinergic drugs. Now you understood all of the parasympathomimetic drugs. Now we are going to the parasympatholytic drugs or anticholinergic drugs. Now I told you everything is going to be really simple because you've already covered your concepts. What are those concepts? I told you the drugs can either be direct acting drugs or indirect acting drugs. What do you mean by direct acting drugs? That means it acts directly on the receptors. These are anticholinergic drugs. So it has to reduce the functions. How will it reduce the functions? By blocking the receptor. That's all. What about the indirect acting drugs? Indirect acting drugs will act via neurotransmitters. Since these are anticholinergic drugs, they will decrease the neurotransmitter, so it will not act on the receptor and functions will be reduced. That's all. These are the mechanism of action of drugs, of both direct and indirect acting drugs. You understood the mechanism of actions. Now, how many types of receptors do we know? We know muscarinic receptors and nicotinic receptors. So there are again two classes of drugs, muscarinic blockers and nicotinic blockers. Muscarinic blockers are known as anti-muscarinic drugs. That is what I told you to remember. One anti-muscarinic drug that is very important for the exam. What is it? It is atropine. Atropine is drug of choice for organophosphate and carbamate poisoning. Yes, this is about the muscarinic receptor blockers. These are also known as anti-muscarinic drugs. Now, nicotinic receptor blockers, again we have two classes of drugs. What are they? Because nicotinic receptors are divided into two, N, M. So we have NN blockers, NM blockers. NN is present in the ganglion, so we call them ganglion blockers. NM is present on the muscles. So if you block the NM receptors, it will cause muscle relaxation. So these are known as muscle relaxants. These are NDMR. These are curium drugs that you study in the anesthesia. Okay, so that's all about the nicotinic receptors. Ganglion blockers are not used commonly. NM blockers, you'll study it in the anesthesia. Now we have to concentrate on the muscarinic blockers for now. So in direct acting drugs, we'll study about muscarinic blockers. That is what is important for us now. So before we studied the classification based on alkaloids and esters, now we'll study it according to the organ. So first we'll go from the top to the bottom. Top we have CNS. Now in CNS we have two drugs that you have to remember for exam. Very, very, very important. First one is scopolamine. Scopolamine is drug of choice for something known as motion sickness. So whenever there is motion sickness, what is the drug of choice? It is scopolamine. Why? Because in the vestibular area we have M1 receptors, and if you block this, it will block this motion sickness. Yes, what is motion sickness? When somebody is traveling in a car, they will feel nausea, vomiting. No, this is because of the movements that happen. This is motion sickness, and the drug of choice for this is scopolamine. Next is benzhexol or benztropine. Benzhexol is also known as benztropine. I already told you, wherever you see the word trop, if you see trop, what is it? It is an anti-muscarinic drug. I told you it is an anticholinergic drug. So benztropine. Benztropine is drug of choice for drug-induced Parkinsonism. This I will teach you in detail in central nervous system. For now, remember it is drug of choice in drug-induced Parkinsonism. That's all. In the brain there are two drugs, scopolamine and benzhexol. These questions have been asked so many times in the exam, I cannot even count it, so many times. Be it NEET-PG, INI-CET, FMGE, doesn't matter. Scopolamine, benztropine will be asked, has been asked. Most important, yes, scopolamine, benzhexol. Scopolamine, it is used in motion sickness. Benzhexol, it is for drug-induced Parkinsonism and drug-induced EPS. Extrapyramidal symptoms, you use benztropine. Okay, next, coming to the eyes. Now in the eyes, what will happen? This is what is important to us. Now in the eyes, what will happen? I told you M3 receptor is present in the eyes. It is causing meiosis and accommodation. If you block this, what will it cause? Mydriasis. So the eyes are becoming bigger. I mean, not the eyes, the pupil size is becoming bigger, and it is easier for us to examine the eyes. So you can do fundoscopic examination. Yes. Now, it is also causing cycloplegia, that means paralysis of accommodation muscles. So it can be used in refractive error testing. So if you know the mechanism of action, you will know the uses. I've already told you. So in fundoscopic examination and refractive error testing, what are the drops that you generally use? You must have gone to ophthalmologist, they must have kept drops in your eyes. What are the drops they are keeping? It is tropicamide. So tropicamide is the drop here. So what are these? Tropicamide, cyclopentolate, hometropine and atropine. Atropine is usually used in children and it is used in the ointment form. Why you study in opthal? Atropine eye drops are contraindicated in children. That is why we give it in the form of ointment. Why? Atropine can be absorbed through nasolacrimal duct, and atropine, when it goes into the systemic circulation, it can cause atropine poisoning. We'll talk about atropine poisoning in a while. Okay. Now, if you understood the eyes, what about secretions? Now, anticholinergic drugs, obviously opposite effect. Parasympathetic nervous system is increasing the secretions. So, these drugs will decrease the secretions like lacrimation, salivation and all of this. So, they can be used as pre-anesthetic medication. Why? If the secretions are decreased, it will decrease the risk of aspirational pneumonia. It will decrease risk of aspiration pneumonia. That is why they are used in pre-anesthesia. Okay, what is the drug? It is glycopyrrolate. Now, in all of these drugs, if I tell you to remember some drugs, it has to be scopolamine and benzoxide. Okay, glycopyrrolate is a pre-anesthetic medication. You'll study this again in anesthesia. Tropicamide used commonly. Atropine ointment is used in the children. Yes. Now, going to the lungs. This is what is important. See, if you activate the parasympathetic nervous system, remember methacholine, what will it do? It will cause bronchoconstriction. Now you are blocking the M3 receptor, so it will cause what? If you block the M3 receptor in the bronchus, it will cause bronchodilation. So these drugs can be used in obstructive airway disorders. Especially these are used in a COPD. It can be used in bronchial asthma as well, but it works better in COPD, so we use it in COPD. Yes, what are these drugs? We have three classes of drugs. What are they known as? SAMA, IMA and LAMA. These are not some fancy woman names, okay? SAMA means short-acting muscarinic antagonist. IMA means intermediate-acting muscarinic antagonist. LAMA means long-acting muscarinic antagonist. Everything is given in the name. So, IPRA is SAMA, Oxy is IMA, Thio is LAMA. This is what I want you to remember. It is given in the name. Tropium, all of these are anti-muscarinic drugs. So, IPRA, Oxy, Thio, SAMA, IMA, LAMA. That's all. Now, coming to the heart. Very important. Which receptor is present in the heart? M2. M2 is what? GI. So, GI receptor is actually blocking SC node and AV node. So, it is contract. It is causing what? Bradycardia and conduction block. Okay. Now, if I give atropine, this will block M2. This will block M2. If it blocks M2, it is blocking the blocker. So, the blocking effect on SC node and AV node are lost, and it will cause tachycardia and conduction. So, it can be used in bradycardia. Do you accept? Why? Because it is causing tachycardia. It can be used in conduction block. Do you accept? Yes. Why? Because it is increasing the conduction, and I've already told you two things before. It is also drug of choice in OP poisoning, carbamate poisoning, and one important question from forensic, it is also useful in early mushroom poisoning. Early mushroom poisoning. In fact, this is the drug of choice there. Why? If they eat these mushrooms, it releases something known as muscarin. Muscarin acts exactly like acetylcholine, and it will have the exact symptoms like organophosphate poisoning. So, what is the drug of choice? Atropine. So, 5 things you have to remember about the atropine. First 3 are pretty important. What are they? It is drug of choice in bradycardia, OP poisoning, carbamate poisoning. Next are conduction block, and the next one is early mushroom poisoning. I want you to remember all of this about atropine. Atropine, very, very, very important drugs. If I tell you 3 important drugs in these chapters, they are first atropine, next scopolamine, next benzoxide or benztropine. I want you to remember all these 3 drugs. Okay. Now, we have finished the heart. Now, we are going into the GIT. Now, in GIT, we have 2 receptors. We have M1, we have M3. M1 is increasing HCl. So, if you block M1, it will decrease HCl. So, it can be used in peptic ulcer disease because it is decreasing HCl. It can be used in peptic ulcer disease. What is this M1 blocker that can be used in peptic ulcer disease? It is pyranzapine and tilanzapine. Have you ever heard these names or seen these tablets? No. Why? Because in peptic ulcer disease, we usually take PPIs. These are the drug of choice. But one INI-CET exam, they have asked what is the M1 blocker that is used in peptic ulcer disease. At least try to remember P for peptic ulcer disease, you use pyranzapine. Now, if you block M3 receptor, M3 is causing the contraction. So, if you are blocking the M3 receptor, it is decreasing the contraction. So, it is decreasing the contraction means it is relieving the spasm. So, that is why we call it antispasmodics. Now, what are the drugs? You've already studied this. One is hyoscine. Hyoscine is also known as scopolamine. We've already studied this. Scopolamine is drug of choice in motion sickness. Next, if you finished scopolamine, next one is glycopyrrolate. Glycopyrrolate is also used for pre-anesthetic medication. The other one is dicyclomine. Only other drug you have to remember. Yes, this is commonly used as well. If you know, yes, women when they get menstrual pains, they use a tablet called Meftal-Spas. It contains mefenamic acid along with this dicyclomine. Okay, that's all. Coming to bladder, this is the hot topic that has been tested in NEET-PG and INI-CET frequently. So it might be asked in FMGE, but it is very important for NEET-PG and INI-CET going people. So you guys keep on asking if this repetition can be used for FMGE or NEET-PG or INI-CET. See, whatever the exam, the concepts are going to be the same. Yes, so there might be some additions here and there that you have to make, but the core concepts are going to be same for NEET-PG, FMGE, INI-CET, doesn't matter. Okay. So, talking about the bladder. Now, bladder, what is the receptor we have? M3 receptor. Now, we have some classes of drugs that are used in the bladder problems. Now, first let me tell you where are these anti-muscarinic drugs used in the bladder problem. Now, let us go to the beginning. Parasympathetic nervous system is causing contraction of bladder, so you can use it in atonic bladder. Okay, but muscarinic antagonist means it will relax bladder. So mechanism of action is relax. It relaxes bladder. So where can we use this? If it relaxes bladder, we can use it in areas where the contraction of bladder is more or activity of bladder is more. That is what we call it as overactive bladder, or we also call it urge incontinence. What happens in urge incontinence or overactive bladder? Bladder is active. That means it is overactive. It is contracting. So in this patient, you will give relaxants. Did you understand? So use is overactive bladder. Okay. Now what are the drugs? Please try to remember: oxybutynin, flavoxylate, fesoterodin, trospium, solifenacin, darifenacin. I know you might feel little intimidated by these things, but I'll give you a mnemonic, easier way to remember this. But please follow the same scheme, okay, same flow. Why? You'll understand in a bit. Yes, please try to remember this. I told you overactive bladder means there is overstimulation of bladder. So how can you treat this? You decrease the stimulation, no? That means you switch off the stimulation. So the treatment is of the stimulated bladder. Those are the drugs. Bas ho gaya. See, O, oxybutynin, F, flavoxylate, F, fesoterodin, of T, trospium, of the stimulated solifenacin. Bladder, you can see here, bladder, Darfur, darifenacin. That's all. Of the stimulated bladder. You can ask me, sir, why do I have to remember in this same scheme? I will tell you. Why this order especially? I will tell you. See, oxybutynin is a very powerful acting drug. So it works well in overactive bladder. If a person is having overactive bladder, if you want to pick an anti-muscarinic drug, which one will you pick? Oxybutynin, perfect, well done, exam. Now, let me give you a case, okay. See, oxybutynin is a powerful acting drug, okay, but it acts on all the receptors. It also blocks M3 receptor, it also blocks M3 receptor in other organs, not just bladder, in the other organs. It also blocks M1 receptor in other organs. Example, brain. If M1 receptor is blocked, it will cause a side effect, dementia. Now you tell me which people have overactive bladder, young people or old people? Obviously old people, no. Old people are usually blessed with many problems. They also seem to have dementia. if a person is having dementia and overactive bladder, which anti-muscarinic drug will you give? Will you give oxybutynin? Tell me, will you give oxybutynin? You should not. Why? It is acting on M1 receptor and it is increasing the dementia. This is the question that has been asked in the exam. So they have given options like oxybutynin, flavoxylate, fesoterodin, solifenacin. What will you pick? Now, let me give you the concept. If you go in this way of the stimulated bladder, so the last two drugs are M3 specific drugs. That means they block M3 receptor mainly on bladder. So mostly they are only blocking the M3 receptor that is present on the bladder and treating the overactive disease or overactive bladder disease. Okay. Now, does that mean it only acts on M3? No, it acts mainly on M3. That means there is some action on M1 also. Very, very little. So it has some dementia. But if you ask me which is better, oxybutynin, flavoxylate, fesoterodin or solifenacin or dorifenacin, obviously answer is solifenacin or darifenacin. Did you understand this much? This is one question. Now I am changing the options. Listen to me carefully. Same options, instead of fesoterodin I am keeping trospium. Oxybutynin, flavoxylate, trospium and solifenacin. Which one will you pick? See, even though solifenacin and darifenacin are M3 specific in bladder, trospium, please try to remember, it is a quaternary amine. What do you mean by quaternary amine? Quaternary amine is water soluble. If it is water soluble, will it cross the blood-brain barrier? See, even though it can act on M1 receptor, it might act on the M1 receptor that is present in the stomach, true. But can it cross the blood-brain barrier and act on the M1 receptor present in the brain and cause dementia? No. That is why this is the best drug for overactive bladder in dementia. Did you understand? Please write this. Overactive bladder with dementia. If they ask which anti-muscarinic drug can be used, obviously the first preference should be trospium. Okay, if not trospium, we can use solifenacin or darifenacin. That is what I want you to remember. That is why I gave you that mnemonic of the stimulated bladder: oxybutynin, flavoxylate, fesoterodin, trospium, solifenacin and darifenacin. Did you understand this much? Once you go from oxybutynin to solifenacin and darifenacin, they will become M3 specific block. But why are we using trospium? Because it is quaternary amine. That is why this is very important for your NEET-PG and INI-CET exam questions. Now, if I ask you what is the drug of choice in overactive bladder with dementia, it is none of these drugs. Which one is the drug of choice? That we will study in the sympathetic nervous system. If you know it, please comment. Okay. Now, after finishing the muscarinic antagonist, so we have done with all the muscarinic antagonist. I already told you about the nicotinic antagonist, that means nicotinic blockers. Now what are we left with? Indirect acting drugs. Now what are these indirect acting drugs doing? I already told you. Indirect acting drugs means it has to act on the neurotransmitter. It should decrease the neurotransmitter. Now how can you decrease the neurotransmitter? You can decrease the synthesis. What is the synthesis? Acetylcholine coenzyme A plus. Acetylcoenzyme A plus, choline forms acetylcholine. Acetylcholine will be released. So how can you block this? See, acetylcholine, it will be converted to acetate plus choline, that I already told you, and then there is choline reuptake. So you can either block this. How can you block this? With the help of hemicolinium. Not been asked in the exam. Hemicolinium, but easy to remember. Hemicolinium means it looks like choline. So body thinks it is choline and takes hemicolinium inside of choline, and it does not form acetylcholine. So it is decreasing the neurotransmitter. But what is very, very, very important for us is botulinum toxin. Botulinum toxin. What will botulinum toxin do? Botulinum toxin will directly block this release of acetylcholine. It will block the release of acetylcholine. That is what botulinum is doing. This question has been asked from microbiology and pharmacology so many times. So botulinum toxin is blocking the release of acetylcholine. Let us suppose if it is blocking the release of acetylcholine, can it act on the NM receptor present on the skeletal muscles? No. then it will relax the muscles. Let us suppose if you are frowning too much, you will have wrinkles here because the muscles are contracted. Now, by giving the botulinum toxin, you're relaxing this and the wrinkles are gone. That is why Botox is nothing but botulinum toxin is used for the wrinkles. Did you understand? Very, very important. Please, please, please study this. Botulinum. Next is hemicolinium. The other one is Vesamicol. Given in the name. Everything is given in the name. See, hemicolinium looks like choline. Okay. Vesamicol. It stops the choline from entering into the vesicle. Again given in the name. Why? Vesamicol. Vesicle में choline को आने नहीं देता है. That's all. Vesamicol, hemicolinium and botulinum. Botulinum is the most important exam going topic that you need to remember. That's all. We have finished all the anti-cholinergic drugs. Now, what is important for us? I already told you about the cholinergic poisoning. Okay. What is happening in cholinergic poisoning? I told, I'll write it here. Yes, see, in the eyes. What is happening? There is increased meiosis. So there is pinpoint pupil. So there is pinpoint pupil. And then there is increased lacrimation. And it will increase all the secretions. It will also increase the salivation. Why? We'll understand this in the sympathetic nervous system. It will cause bronchoconstriction. In the stomach, it will increase contraction. In the GIT, increased contraction. So what will happen? It will cause diarrhea. And in the bladder, it will increase contraction. So it will cause urinary incontinence. That means there is a lot of urination. Sweat glands, it will increase the sweating. See, salivation, we've already talked about it. I'm talking about the sweating. Sweating thing you'll understand in the sympathetic nervous system why there is sweating. Now, about the heart, it will cause what? It is decreasing the heart rate. So it will cause bradycardia. Muscle, it will cause muscle weakness. What is the drug of choice in all of this? Atropine. So drug of choice for OP poisoning, carbamide poisoning or cholinergic poisoning. Cholinergic poisoning is happening because of OP and carbamide. Let us suppose you are giving atropine. See, atropine is usually given in the 2 mg injections. So you have to keep on repeating until there is atropinization. Unfortunately, if you give too much of atropine, other than atropinization, there will be the side effects. It will cause toxicity. So that is what is known as anti-cholinergic poisoning. So anti-cholinergic poisoning can happen because of atropine. How? Either if you give too much of atropine or accidental ingestion of atropine. See, atropine comes from Atropa belladonna. It also comes from datura. So if a person eats flowers and fruits of datura, Atropa belladonna or takes so many injections of atropine, it can cause anti-cholinergic poisoning. So what will be seen in anti-cholinergic poisoning? Exactly opposite to the cholinergic poisoning. Here the patient will have mydriasis, decreased lacrimation, decreased salivation. So if there is decreased lacrimation, there will be dry eyes, decreased salivation, dry mouth, bronchodilation. Next, it will cause relaxation of what? Stomach and GIT. So it will cause constipation. What about the urine? Again, relaxation of bladder. So there will be urinary retention. Now, what about the heart? It will cause tachycardia. Now, what about the brain? In the brain, it will cause delirium. So that is when you understand, when you give atropine in a higher dose, it will cause delirium. And it will cause all these symptoms. How do you treat it? This is the important question. See, this is anti-cholinergic poisoning. Okay. So in cholinergic poisoning, you are giving anti-cholinergic drug, that is atropine. In anti-cholinergic poisoning, you should give cholinergic poisoning. No, common sense. So you have to give a cholinergic drug. That much you understood. Which cholinergic drug will you give? Which cholinergic drug will you give? See, on the muscarinic receptor, atropine is coming and sitting and it is blocking the receptor. So if you want to bring the atropine out of the receptor, you have to increase the neurotransmitter, that is acetylcholine. That is what we have done in myasthenia gravis. Here also we are doing the same. Did you understand this much? How can you increase the acetylcholine? By giving the indirect acting drugs. So which indirect acting drugs will you give? Irreversible are poisons, so we don't give. Reversible drugs we will give. Okay. Irreversible, how many classes of drugs do we have? We have tertiary amines, quaternary amines. Now, quaternary amines will not cross the blood-brain barrier. So, will it work in the brain for delirium? No, it will not work. So, you will not give quaternary amines. What is left? Tertiary amines. In tertiary amines, what are the drugs we have studied? Tacrine, donepezil, rivastigmine, galantamine. I've left out one single drug, that is physostigmine. It is physostigmine. So physostigmine is the drug of choice in anti-cholinergic poisoning or atropine poisoning or datura poisoning or atropa belladonna poisoning. Did you understand this much? That's all. We have covered all the drugs in the parasympathetic nervous system, most high yielding topic for the exam. That's all. Most high yielding. I promised you that I'll talk about physostigmine. Now I did. We'll go to that page and fill it up. Physostigmine is the drug of choice in anti-cholinergic poisoning. So now we will write. See, what is the drug of choice for atropine, datura and anti-cholinergic poisoning? It is physostigmine. What is the drug of choice for diagnosis of myasthenia gravis short acting? Edrophonium. Now symptomatic treatment, what can we give? Long acting pyridostigmine. So you can see one theme here. Whenever you see the name stigmine or chol, both of them are cholinergic drugs. Okay. When you see the name trop, it is anti-cholinergic drug. That's all. It is anti-cholinergic drug. Easy way to remember this. Yes. Now, where do people get confused in the exams? So let us suppose they will ask you the symptomatic treatment of myasthenia gravis, which drug are we using? And in the options they will give both pyridostigmine and physostigmine. Both of them look the same. Always confusion happens here. So what can we do? You can see the spelling properly. Pyridostigmine. Yes. What is there? Y and R. Okay. Same thing with myasthenia gravis. Myasthenia gravis. Y and R. So at least try to remember it this way. Easy way to remember pyridostigmine, Y and R. Please don't get this wrong. You'll get it in the exam definitely. Okay, don't get this wrong. Pyridostigmine, physostigmine, don't get confused. If you are getting confused, remember Y and R, myasthenia gravis, it is pyridostigmine. Physostigmine is for anti-cholinergic poisoning. That's all. We have done with all the drugs of parasympathetic nervous system. Now we will try to see how the questions are asked, and after that I'll give you 2 to 3 minutes for you to revise all of these ones. Okay, so we'll see this drug. Yes, methacholine is used in the bronchial asthma challenge test. Okay, I've already told you this. The effect observed here is due to action on its which receptor. So you have to understand this. Methacholine, okay, cholinergic drug, it is used in bronchial asthma challenge test because the effect is bronchoconstriction. Yes. So bronchoconstriction means the effect is on bronchus. On bronchus, which receptor is present? I already told you M1 is present in brain and stomach. M2 is in heart. I told you, mature person, no? M3 is in rest of the body. So M3 is present on bronchus. Answer is M3. That's all. This is the question that has been asked in NEET. So I told you, if you remember this flow and scheme, you will be able to answer even the new questions that you will get. That is why concepts are really important. Okay. So same thing. Next question. This is how questions are asked nowadays. They will not ask you what is the drug of choice for this. Unfortunately, they will not give you drug of choice for cholinergic poisoning in the options. That is in the olden days. Now they are giving you clinical scenarios. That is why I prepared these questions for you. Okay. A 48-year-old woman presents with 6 months history of gritty sensation in the eyes, difficulty swallowing dry food, and recurrent dental caries. Why? Because the salivation has decreased. No. Here there is decreased lacrimation. On examination, she has markedly reduced tear production. That is what I told you, decreased lacrimation. This is what is known as positive Schirmer's test. And there has been parotid gland enlargement, and the laboratory testing reveals anti-Ro antibodies. Anti-Ro antibodies. So anti-Ro antibodies, dry eyes, dry mouth, all of these can be seen in which syndrome? It is Sjogren's. I've already told you, in Sjogren's syndrome we can use pilocarpine, but which is better? Cevimeline. So what is the answer? Semi-myelin. That's all. Ho gaya. Yes, easy to understand. Good. Now, a 42-year-old farmer is brought to the emergency department after accidental exposure to insecticides. Easiest question. He itself has told you that there is accidental exposure to insecticides. I already told you insecticides and pesticides are either organophosphate or carbamate. So there has been accidental exposure to insecticides while spraying his crops. There is increased sweating, salivation, lacrimation. On examination, he has meiosis, increased urination, his pulse is 50, so there is bradycardia. All the symptoms of organophosphate and carbamate poisoning. Respirations are labored. Why? Because he is having bronchoconstriction. Which of the following is the drug of choice in this condition? Easy. Cholinergic poisoning. What is it? Anti-muscarinic drug. Which one? Atropine. That's all. Has been asked so many times in the exam. You should not get it wrong. Okay. Now, fourth one. A young female patient presents with ptosis, which repeatedly worsens in the evening and improves in the morning. Very classical point that has been asked here. Yes, you must have studied in medicine so many times. That is myasthenia gravis. In myasthenia gravis, we have ocular myasthenia gravis, ocular MG, and generalized myasthenia gravis. In ocular myasthenia gravis, eye muscles are affected, so there is ptosis. Did you understand? So, which drugs can be used for diagnosis this condition? Diagnosing this condition means myasthenia gravis. It is tensilon test. No, I already told you. Short-acting drug. Which one? Edrophonium, neostigmine, or pyridostigmine? It is edrophonium. So this is the answer. That's all. Easy to answer, isn't it? So next, a child presents with history of ingestion of unknown fruit. We don't know which fruit is it. Okay. He develops delirium, dry mouth, mydriasis, tachycardia, constipation. All of these are symptoms of anti-cholinergic poisoning. That is what we have studied. So in anti-cholinergic poisoning, we have to use cholinergic drug. That is a tertiary amine. What is this? It is physostigmine. So if you know the concepts, you don't even have to look at the options. That is what is physostigmine. That's all. Simple, isn't it? Now, so till now, we have finished the parasympathetic nervous system. Next, after doing the sympathetic nervous system, we'll go through the other questions. So, did you revise the parasympathetic nervous system? Yes, you understood parasympathomimetics and parasympatholytics. Now the schema is going to be the same.